This video is created for physiotherapy education and learning purposes only. The demonstrations and/or explanations are as per our experiences and are generalized and may not be appropriate for every patient or condition which is more specific. This content should not be used as a substitute for textbooks but just as an aid to formulate answers better.
Hello, this is Dr. Ravina here, and today we are going to discuss the normal and altered kinematics of cervical spine. Normal kinematics is an important topic and always asked in second BPT papers, and altered kinematics could be of interest for students who are in final year or interns or even the master students because it is asked as pathokinematics in their papers. Let us look into each aspect one by one, beginning with normal followed by altered kinematics. Proceed, let's look at the different types of cervical vertebrae. Broadly, they are classified as typical cervical vertebrae or atypical cervical vertebrae. Atypical cervical vertebrae involves C1, C2, and C7 because their characteristics are slightly different from the remaining typical cervical vertebrae. So it consists of a body whose transverse diameter is greater than the anteroposterior diameter. So it's a small vertebral body. It has small transverse process with a classical transverse foramen that accommodates the vertebral artery. It has facet joints, which are superior articular surfaces and inferior articular surfaces or processes, which are aligned in frontal and transverse plane. It has a large intervertebral foramen, which accommodates the spinal cord, and a bifid spinous process. It also has this uncinate process, which is also called as uncus, which is the slight elevation that you can see on the sides. That is about the typical cervical vertebrae. Now, there is C1, which is atlas, which is slightly different because the body is more or less absent. So you have like a ring and two side surfaces that are present, which articulates with the occipital condyles. Following which you have C2. It does have the bifid spinous process, but it has this prominent pointed surface which is called as the dens that is used to articulate with the atlas. So atlas is nothing but a washer between the occipital condyles and the rest of the cervical vertebrae. Likewise, the axis is a connection between the head and C1 with that of the rest of the cervical vertebrae. Likewise, C7 also has slight differences in the fact that it has a very long spinous process. Let us now look at the ligaments of the cervical spine in brief. So anterior vertebral bodies are connected by the anterior longitudinal ligament. They are continued as the anterior atlantooccipital and atlantoaxial membranes at the atlas and axis. Posteriorly, we have the posterior longitudinal ligaments, which are connecting the posterior parts of the body, which continue as the tectorial membrane in the atlas and axis area. Thereafter, connecting the lamina are the ligamentum flavum, which continue as the posterior atlantooccipital and atlantoaxial membranes around the atlas and axis. Connecting the spinous processes are called as the interspinal ligament, which is shown in green. And finally, we have the nuchal ligament or ligamentum nuchae, which basically is a thick triangular sheet-like structure that connects the foramen magnum and external occipital protuberance proximally to the C7 spinous process distally. Let us now look at the general characteristics of the cervical spine. First of all, magnitude of movements, that means the degree of range of motion, increases from C2 to C7 progressively. Moreover, the movements that are allowed are flexion, extension, rotation, and lateral flexion. And majorly in the atlantooccipital joint, we have a particular movement which is nodding that occurs there. So there are various factors which dictates the movement of the cervical spine. As we know that it comprises of two joints, which is the intervertebral joints between the vertebral bodies and the facet joints. Now facet joint in cervical spine, if you see the superior articular facets, they are oriented superiorly and posteriorly. Inferior ones are oriented anteriorly and inferiorly. So they are lying in such a plane that the movement there occurs between transverse and frontal planes. So that's how they dictate the movement at the cervical spine. Likewise, in the vertebral body, as we had discussed previously, there are these elevations which are called as uncinate processes from C3 to C7, which eventually form the uncovertebral joints of Luschka. So both these things, that is facets and the vertebral body or intervertebral joints, they both dictate the movement at the cervical spine. So basically, as discussed previously, we have three planar movements occurring at the cervical spine. One is flexion and extension that has a range of about 126 degrees with a standard deviation of 22 degrees. About 15 degrees coming from Atlantooccipital joints, 15 coming from Atlantoaxial joints, and 105 degrees coming from C2 to C7 joints. So basically, lower cervical and middle cervical have larger contributions to flexion and extension. The axis of movement is frontal or mediolateral, and the plane is sagittal. Likewise, we have the lateral flexion movement, which basically has a range of 87 degrees with a standard deviation of 22 degrees. Here it is Atlantooccipital joint to one side, that means either right side or left side, contributing about 5 degrees of lateral flexion. Atlantoaxial is almost negligible, and C2 to C7 again you get maximum, which is 35 degrees on each side. Axis of movement is sagittal, plane is frontal. And rotation, the total rotation range is 144 degrees with a standard deviation of 23 degrees. Here Atlantooccipital is contributing negligible. Atlantoaxial is the one that gives 40 to 45 degrees because it has the dens which forms the pivot with Atlantoaxial. And there is the C2 to C7 which comes and gives 45 degrees on each side. So the axis of movement is vertical and the plane is horizontal. Let us first look at the arthrokinematics of flexion and extension. We have divided it joint-wise into three parts, which is what movement happens at Atlantooccipital joint, what happens at Atlantoaxial, and what happens in the lower cervical vertebrae. Now, if you look at the Atlantooccipital joint, the occipital condyles are basically convex, so they roll backwards while they slide forwards in extension, and they are rolling forward while they slide backwards in flexion. So the stabilizers of Atlantooccipital joint movements are basically the tension that is generated in the tectorial membranes and the articular joint capsules. Looking at the atlantoaxial joint, basically the atlas pivots forward during flexion and backward during extension. Here, because the dens, which is the elevated structure of the axis, is present, that acts as a stabilizer to the movement. Likewise, looking at the lower cervical vertebrae, during extension, the inferior articular facets of the superior vertebrae, they slide inferiorly and posteriorly in comparison to the superior articular facets of the inferior vertebrae. Likewise, in flexion, the inferior articular facets of the superior vertebrae slide superiorly and anteriorly when in compared to the superior articular facets of the inferior vertebrae. So basically, in extension, the vertebral body also rotates and slides posteriorly. Likewise, in flexion, it rotates and slides anteriorly over the inferior cervical vertebrae. So all the movements that are described here are of the superior vertebrae with respect to or in comparison to the inferior vertebrae. So here the stabilizers in flexion and extension of the lower cervical vertebrae are in extension, it is a closed back position because all the spinous processes kind of come in contact with each other and the facets also come in contact with each other. And if you see flexion, it is basically the capsule, the tension that's there in the capsule of the apophyseal joints, which are restricting the movement further and stabilizing the joint. So in an ideal situation, flexion and extension both should be initiated in the lower cervical spine, thereafter followed by the upper cervical spine. But in most cases, when people with forward head or chin poke postures, etc., the lower cervical spine is already into flexion, which is why we see a hump, whereas upper cervical spine becomes more hypermobile and compensating for the range. So ideally, your flexion and extension should be from the lower cervical spine followed by upper. Discuss the arthrokinematics of lateral flexion. As discussed earlier, atlantoaxial joint contributions to lateral flexion is negligible, so we have not included it here. So if you see the atlantooccipital joint, there is a side-to-side rolling of the occipital condyles that occurs on the atlas. So if I am doing right lateral flexion, right-sided occipital condyles compress the right-sided lateral mass of the atlas or the articular facet of the atlas. So stabilizer will be your tension in the joint capsules which are there of the lateral apophyseal joints. Likewise, in the lower cervical vertebrae, if I'm doing right lateral flexion, then the inferior articular facets on the right side, they will slide inferiorly and posteriorly. Whereas the inferior articular facets on the left side will slide superiorly and anteriorly on the superior articular facets of the next or the lower cervical vertebrae. So basically the stabilizers are the facet joint orientations itself here which prevent, and of course there are muscle tensions also like your trapezius on the opposite side which can kind of control the movement from over happening. In ideal scenario, lateral flexion is initiated in the upper cervical spine and then followed by the lower cervical spine. So looking at the arthrokinematics of the third and the final movement, which is rotation, as we discussed earlier that there is a ring-shaped atlas around which the dens of the axis is present, which allows it to spin around in the rotation movement. So atlantoaxial joint is stabilized by the tension in the alar ligaments and the capsule of the apophyseal joints. Now we have not discussed atlantooccipital joints here as discussed before because the movements coming for rotation from there are negligible. However, in lower cervical vertebrae also rotation does occur where the inferior facets slide posteriorly and inferiorly on the same side of rotation. That means if I'm doing right rotation, then the inferior facets there slide posteriorly and inferiorly while it goes anteriorly and superiorly on the left side when I'm doing a right-sided rotation. So again here the stabilizers become the facet joint orientations. So in ideal scenario, rotation is again initiated in upper cervical spine, precisely in the atlantoaxial joint, then followed by the lower cervical spine. Classic feature of cervical spine is the occurrence of coupled movements. Whenever there is rotation movement that tries to occur in the cervical spine, it may be accompanied by lateral flexion. Now, if there is lateral flexion that is occurring in the cervical spine, it may be accompanied by some amount of rotation. So if you see the upper cervical spine, the rotation and lateral flexion occurs in opposite direction. That means if I am intending to do right rotation, there may be associated left lateral flexion that can occur. Likewise, in the lower cervical spine, rotation and lateral flexion occurs in the same direction. So if I am doing right rotation, it may be accompanied by some right lateral flexion as well. Let us now discuss the altered cervical spine kinematics. Just for the ease of remembering, we have developed a mnemonic which is motion safe. Mobility changes, out of sequence timing, translation abnormalities, instability, odd coupling, increase in neutral zone, scapular dysfunction, arthrokinematic faults, faulty motor control, and end-range aberrations. Now let us look at each one in detail in the subsequent slides. Let us look at the first point, which is motion changes. Now, if you look at this X-ray, you can see all these degenerative changes that are occurring. There are a lot of osteophytes that are formed. The square shape of the vertebrae is lost. So what happens is wherever there is degeneration or reduced disc space, automatically there is hypomobility that might occur here. Now, obviously, the person would still want to do the movements. So now where should he get the additional movement from if those areas are hypomobile? Then the adjacent vertebrae, which are above and below, they start becoming hypermobile to compensate for the hypomobile areas. So these motion changes can definitely occur the normal kinematics of the cervical vertebrae. When we see that the lower cervical is moving too early or too late in the range, or upper cervical is overcompensating for the range, that tells us that there is an out of sequence timing. So we had discussed previously that in flexion and extension it should start from lower, then go to upper, and likewise in rotation and in lateral flexion it starts from upper then go to lower. But if there is a mismatch in the sequence, it is called as out of sequence timing. Sometimes when a person is asked to do cervical flexion, they might do a chin poke, like in the x-ray that is shown. There may be a chin poke before there is a cervical flexion. So all these things are good examples of out of sequence timing. There may be something called as translational abnormalities. So as we had discussed, that intervertebral sliding should occur to bring about the range. So if there is excessive hypermobility or reduced hypomobility in sliding movement between the vertebrae, then these are called as translational abnormalities, which can restrict the range and alter the kinematics. Sometimes if the person has undergone any kind of whiplash injury or trauma, or the person has a ligament laxity or ligament injuries, there may be instabilities that can occur in the cervical segments. Now these two x-rays are basically flexion views. That means the person is asked to flex the neck, and this is the extension view, which is B. Now if you can see here, the vertebrae are more or less in line, slightly altered here. But if you do the extension, you can see a clear-cut alteration in position here of this vertebrae with regards to the rest of the vertebrae. That tells us that in certain positions the ligaments or the articular structures or the surrounding structures are not strong enough to hold the segments in place. So these are called as listhesis or lysis. So if it is at the pars interarticularis where there is a separation of the vertebral body from the rest of the structure, it is listhesis. Whereas if the entire segment or the vertebrae shifting, then it is lysis. So we need to understand that instability can also alter the kinematics because the appropriate glide and roll may not occur like it occurs normally. We had previously discussed the concept of coupled movements, where with rotation some amount of lateral flexion occurs and vice versa. But now in cases where there is a facet dysfunction or postural changes like scoliosis, or if there are muscle guardings, etc., there may be alteration in these coupled movements further, which alter the kinematics and the range of motion eventually. Whenever there is an increase in the neutral zone, there is some amount of micro instability in the neck that can be detected, because the range of movement that is allowed inside the intervertebral joints or between the intervertebral joints is more, because the resistance that it gets from the rest of the spinal column is minimal. So that's when your neutral zone increases and instability increases in the neck, which again alters your arthrokinetics. Scapular dysfunction is a very valid cause of alteration in cervical kinematics, because multiple muscles are there which probably originate from the neck and insert into the shoulder girdle. So there's a good connection biomechanically between the neck and shoulder. So any dysfunction that occurs in the scapula, you can expect some amount of dysfunction to occur in your cervical spine as well. One good example of the muscle is the trapezius. So if there's any kind of spasm in the trapezius, neck movements also get altered, and to some extent elevation of the shoulder girdle also gets altered. Let us now understand what are arthrokinematic faults. Now whenever there is an alteration in the joint surface mechanics, so for example, now if we say that there is facetal arthropathy, or if there is some meniscoid body like it is shown in the image, it comes in the way of the facet. So when it starts compressing, the person experiences pain, and there may be certain range of motion restriction in extension or lateral flexion or rotation where the facets get compressed. So if there is any issue in the surface mechanics, that can also lead to arthrokinematic faults. There's a very important concept called motor control. So muscles have to function at a specific timing to bring about a certain movement. If certain muscles overact and certain muscles are weak and underact, then you do not have a proper motor control which brings about the movement. So if you see in the cervical spine, if the lower trapezius and the deep cervical flexors get weak, we generally see that sternocleidomastoid, scalenii, levator scapulae, and upper trapezius are overpowering in that area. And that can lead to altered kinematics, and further degeneration can be promoted by these altered kinematics. There are certain end range aberrations that can occur. Basically, they are painful arcs. If there's a catch or a shift at the end of range, that can also affect the smooth termination of the movement, thereby altering the kinematics. So, as a second year, if you have to answer the question of cervical kinematics, first and foremost, describe the structure of cervical spine in brief with diagram if possible, like I have tried to explain, along with the ligaments and all of that. Little atypical and typical vertebrae, try to just classify that in brief. Following that, you provide a table that tells you about the range of motion and which plane and axis the movements are happening. After that, explain the glide and roll in each particular movement and the direction in which it is happening, along with the reason of why it is happening based on concave convex rule, and divide it into those three joints like I have done: Atlantooccipital, Atlantoaxial, and lower cervical. And pointers would be easier so that it's easier to understand for the examiner as well what you have tried to explain, and eventually just describe the sequence, whether it is the upper cervical which should be starting or it is lower cervical which should be starting in the movements. That should help you with the answer of cervical kinematics. If as a final year or as a PG you're asked about altered cervical kinematics or the pathokinematics, you will first describe the normal kinematics in brief and simultaneously start describing each of the altered kinematics that we have discussed in the second half of the video. And I've tried to give a lot of examples in each one, like I've spoken about cervical spondylosis, scoliosis, forward head, chin poke, uh, listhesis, facetal arthropathy, etc. You can involve that in your answer and just briefly explain how there is an alteration in the kinematics in these conditions as compared to normal. That's all about this. Thank you so much for watching.